to carry the oxygen, right? طيب, if I have low hemoglobin, yeah, I have less hemoglobin to carry the oxygen, so I mean I'm breathing well, but the oxygen is not reaching the organs, from the lungs, it's not reaching the other part of the body. Okay, because I have good oxygen coming to the lungs, but nobody there to receive. Okay, all hemoglobin is full, but I need more hemoglobin to deliver all of this oxygen to the body. So this is maybe due to anemia. You will have hypoxia, right? So in this case, I have anemia due to hypoxia. Now another thing, if I have let's say the hemoglobin itself is full of other gases, like for example carbon monoxide toxicity, CO2 and CO. What's the difference? Yeah, this is dioxide, this is monoxide. This is CO2, 2 oxygen. This is CO, 1 oxygen. The CO2 is a gas that can be dissolved in blood and released from blood by pressure only. Okay? Or difference in concentration. While the carbon monoxide, once it goes to the blood, it's just like a glue. It attached to the hemoglobin like a glue. So it's stuck to the hemoglobin, then is not leaving the hemoglobin. Then no space, all the hemoglobin cells, all hemoglobin molecules is full, and you cannot carry oxygen. So carbon monoxide decrease the functionality of available hemoglobin, even if the patient have good hemoglobin level. Okay? So when you measure the oxygen saturation, SpO2 or SaO2, you measure how much oxygen in the hemoglobin. Okay? But there are other oxygen that dissolve in the water, in the blood, not attached to hemoglobin yet. This is, we measure it by BaO2. Okay? So oxygen, total oxygen in the blood is equal to how much oxygen in the water, which is in the plasma, and how much oxygen in the hemoglobin, attached to hemoglobin. How to measure the oxygen attached to the hemoglobin? Huh? Measuring? Sorry? Measuring what? If you want to measure the oxygen attached in the body, in the blood, that is attached to hemoglobin, which measurement you will use? Huh? PCO2 or SpO2? SpO2. If you want to measure the oxygen that's dissolved in the plasma, PaO2. PaO2. So PaO2, partial pressure of oxygen, is how much oxygen in the plasma. Saturation, how much oxygen attached to hemoglobin. Okay? 2 types or 2 places for oxygen to be in the blood. 1 part in the plasma and 1 part in the hemoglobin. Blood, 2 parts, plasma and hemoglobin. Okay, guys? Now, partial pressure of oxygen in venous blood. What's the meaning of this? PaO2 arterial, PVO2 venous. So PVO2 is how? Which oxygen? PVO2. The oxygen that is in the plasma or in the hemoglobin? Plasma. Because just the difference, this is arterial, this is venous. This is the only difference. This is partial pressure of oxygen. This is in the plasma. This arterial plasma, this is venous plasma, okay? Okay guys? Right. Next thing is VO2. So this is all measured in oxygen in hemoglobin or plasma? Hemoglobin. In artery or venous? In vein. Venous, okay? Just remember this concept. Now, so total oxygen, it will be hemoglobin bound and dissolved in plasma. Total. The total oxygen in the blood, part of it will be in the plasma, part of it will be hemoglobin bound. Okay guys? Clear this part? So this is the oxygen content in the blood. So there is measurement and calculations for this. It depends on how much hemoglobin you have and how much oxygen attached to this hemoglobin. Okay? So if the patient have good hemoglobin and good oxygen attached to hemoglobin by measuring saturation, measuring hemoglobin, you have good oxygen content in hemoglobin only. Then you will have the other part, how much oxygen in the plasma. Okay? So you measure that by PO2. Yeah? So when you measure the PO2, it will affect how much oxygen in the plasma. Okay? So you always want good hemoglobin, good saturation of that hemoglobin, and good oxygen dissolved in the plasma. Okay? So if the normal person should have, let's say, hemoglobin 14 grams and saturation 98 to 100%, the PO2, how much pressure or oxygen in the plasma, 100 millimeter mercury. If we put in this equation, it will be in arterial blood 20 ml of oxygen in each 100 ml of blood. Okay? This is just to demonstrate the importance of these values. Hemoglobin, saturation, PO2. Okay guys? Now, I will see my tissue will take from the 25 only. It will not take all the 20. You know which 20 I'm talking about? Huh? I need, which 20 I'm talking about? You read. Which 20 I'm talking about? Huh? I said there is 20. I'll take from this 25. Previous slide we are talking about 20 ml of what? No. If you are like something that's not clear for you, just stop me. We will not proceed unless you clarify, unless you understand, okay? This is just not time to pass only. I need you to be like 100% understand as much as I understand, okay? And this one? This one? Huh? This one? Okay, so you need how much hemoglobin in blood, how much oxygen in the blood is equal, affected by how much oxygen in the hemoglobin and how much oxygen dissolved in the plasma. Okay? Does anybody have any difficulty to wrap his head around the concept of oxygen dissolved in the plasma and the hemoglobin, attached to hemoglobin? Anybody have difficulty? Is it clear? Okay. So now I have two parts for the oxygen. One attached to the hemoglobin, which is affected by how much hemoglobin and how much oxygen attached to the hemoglobin. The other part is dissolved in the plasma, which is measured by how much PO2 or how much pressure that oxygen exerts in the plasma. So PO2 reflects how much oxygen in the plasma, and saturation and hemoglobin reflect how much oxygen in the hemoglobin, attached to hemoglobin. Okay guys? So this calculation, you will put the hemoglobin value, then you will put the saturation, then you will put the PO2. We will calculate how many oxygen per 100 ml of blood. It turns out it's 20 ml per 100 ml of blood. 20 ml of oxygen. 20 ml of oxygen. See, these numbers are measuring pressure, this measuring percentage, okay? Does not measure how much oxygen. So if I want to know how much oxygen actually, because you can know how much oxygen, this oxygen is a gas. You can measure gas by ml, right? Like when you measure the gas, the oxygen flow, how much you measure? when you turn on the flow of the oxygen. How much is the flow of oxygen? Start with what? Huh? One what? One what? Liter. 1 liter. Liter is how many ml? 1000. 1000 ml. So you can measure oxygen per ml. So how many ml in the blood? I will say 100 ml of blood. So 20 ml of oxygen, 100 ml of blood. This blood, an artery. This artery will go to the organ, let's say kidney. The kidney will take away needed oxygen, sir? So the kidney need oxygen, right or no? Sir? It will take all the 20? No, it does not take all the 20. So it will take 5 only. So tissue extraction is 5. Then it will return the blood in the vein. So in the vein, I will have 20 or how much? 15. The remaining. So then you will have the remaining volume is 15 ml. So venous blood will have 15 ml. I can calculate the tissue extraction. Can I measure the tissue extraction? Can I measure how much the kidney took? How? You cannot. So how can you predict how much the kidney took or organs took? Venous. So you compare venous with arterial. Yeah, compare venous and arterial. Before and after. Before and after. So the blood lost how many oxygen before to after. Then this is how much oxygen is used by my body. So when you take ABG, it's good also to take VBG. Okay? VBG. And the best VBG to take the one from the central line. Because it's mixed between all venous and it is only in the heart. So if you took one vein from here, so means you are measuring oxygen extraction from the hand. If you measure it in the legs, the vein, the femoral vein, you are taking from this leg how much oxygen consumption. When you take it from here, this is mixed between all body, all venous blood. It will be mixed here, right? Yes. So it's not known only local to hand or any organ. So when you take it here, so it's called mixed venous. Okay. So oxygen therapy, we want to give higher than room air. So in room air, you will have 0.3 ml of oxygen and 100 ml. While when you put 100% oxygen and face mask, for example, or non-breather mask, with atmospheric pressure, you will have 6 times the room air, 6 times the volume. So that's why the total will be in the inhaled air, it will be 1.8 ml per 100 ml of blood. So it will increase the level of the arterial blood by 1.8. By 1.8. Okay? So there are types of hypoxia. If your problem only is that you have low oxygen, so the patient is inhaling some air, that this air is having low oxygen. Let's say he is suffocated or he's not breathing. He's not taking enough oxygen. So how to treat this patient? Give him oxygen. He just needs oxygen. Give him oxygen. Like if you have anemia, you are giving him enough oxygen, but saturation is low or like he have hypoxia. So how to treat? Yeah, give him blood, give him hemoglobin. Okay? Stagnant hypoxia means that I have good oxygen reaching to the lungs and the lungs to the heart, but let's say the patient have hypotension and the blood is not reaching the organs properly. Okay? So I have hypoperfusion. You know hypoperfusion? Yeah, so you have perfusion, normal perfusion, and you have less than normal. So the normal delivery of blood is less than the adequate amount. So I don't have good delivery. So stagnant hypoxia. So the blood stays in the, let's say, let's talk about any organ, the kidney. The blood reaches the kidney. There is no blood pressure enough. So the circulation is slow. It's not going back to change with the new oxygen. It is just staying longer time in the kidney. So the kidney take all the oxygen from the blood. And instead of taking 5, it will take 15. Okay? Then until there is no oxygen in that blood, then it will be hypoxia due to stagnation or slow circulation, or probably happen to hypovolemic patient or hypotensive patient. Histotoxic hypoxia happens if the cell itself cannot use oxygen, like if some types of poisoning, like cyanide poisoning. So the cell itself unable to utilize the oxygen. So in hypoxic hypoxia, I need to give oxygen. This is the main benefit. But in anemic hypoxia, if you increase the oxygen, it will not benefit. All hemoglobin is full. In stagnant hypoxia, if you give oxygen, it will not benefit. You need to improve the blood pressure. Right? You need to give the patient fluids if you have less fluid. If you need to give something to increase blood pressure. Okay? Histotoxic hypoxia, there is no benefit because the cell will not utilize that oxygen. So you need to give antidote to return the function of the oxygen utilization in the cell. So when you see this patient is hypoxic, what symptoms you see? Yeah? Bluish? Discoloration. Okay, what else? What do you think? What other symptoms? Now he have hypoxia. How this affects him? Shortness of breathing. Yes, so he's having shortness of breathing due to hypoxia. Actually, it's like which effect? The effect of the shortness of breathing is hypoxia. So if the patient have hypoxia, this oxygen is utilized in all organs. Which organ is more sensitive for hypoxia? More than heart, more than kidney, brain, because the brain does not save any energy or oxygen, does not save or have a storage, like for, let's say, starvation time. The brain does not save anything. There is no space in the brain to save anything. Does not save energy, carbohydrates or fats or oxygen, does not save anything. So once you have low supply, it will have the effect. So the effect in the brain is hypoxia. In hypoxia, what will happen to the brain? What behavior changes? What will happen to the patient? You will see. Sorry? Of course, but how can you see this on the patient? Decreased level of consciousness. What else? Sorry? Giddiness? Giddiness. What's this word? What do you mean by giddiness? Dizziness? Dizziness, okay. So dizziness. What else? What else? Restless. Agitation. Okay? So you can see easily patients starting to become irritable, removing gown and lines and cannula dressing and shouting, throwing food. Think about this. Okay? So also disoriented, confused, also gasping and trying to breathe harder, and also you'll see heart rate increases. If this patient having this hypoxia for a long time, let's say it's not severe, it's just mild, but it's hypoxia, but it's long time. Like in some diseases, like chronic obstructive pulmonary disease, COPD. Did you hear about COPD? Yes. Those patients, or chronic smokers, or like chain smokers. Chain smokers will damage their lungs, and it will not be able to utilize the oxygen as before, so the body will have hypoxia. So they will have symptoms that's chronic for them: fatigue, drowsiness, and they are not working as normal. They cannot work for 2 hours straight, for example. They are easily fatigued if they take the stairs. So their capacity will be less. And also by long time, the body will have some adaptation, okay, like the lung capacity will increase and you will have the pigeon chest or barrel chest. This means the lung try to inflate, the body try to inflate his, because as compensation, okay, so you will see the shape of the chest is different and you see the fingers of the patient swelling, but it's not swelling, it's like that. It's not overnight. This is over 3-4 months. Okay? It's called finger clubbing. Finger clubbing. Okay? So what you need to assess if the patient have hypoxia, what things you need to assess? Oxygen levels. What else? Yes. Oxygen levels in EBG. What else? Assess what? Breathing pattern, exactly. What else? What else? We said something now, just in previous slide. What we will assess on the patient? Assess what? Assess what? Color of the skin. Okay. What else? Appearance. What else? Assess what? Vital signs, what else? Assess what? Symptoms, patient behavior, okay? When you have pulse oximeter, so the pulse oximeter is not invasive. It's just applying in the skin, it will measure. It does not prick the skin. You are not taking blood sample. It's good, fast, quick, safe, okay, but they have a problem. If there is something between the probe and the skin, or something with the patient itself, it does not give you accurate reading. Possible causes, let's say if the patient have artificial fingernails, like they just attach fingernails, or they have the pigmentation, okay, and they just put the nail polish, or movement, patient moving, or also if the patient have cold hand, severe like hypothermia or hypotension, it can give you errors in the reading. So how to assess oxygenation? ABGs, as you said, and you want to start oxygen therapy if you saw PaO2 less than 60 or saturation less than 90. So this is the indication to start oxygen therapy. These numbers, 60 or 90. 64, which one? PaO2. Saturation, 94 saturation. Okay? So less than 90 or 60. So now you will try to deliver oxygen therapy. Okay, you will use oxygen delivery devices. Okay? So what are the oxygen delivery devices? There are many things. Okay? Nasal cannula, face mask. Exactly. So which one you will choose? First of all, you will think about how much? Yes, oxygen saturation. How much you need? Okay, if it's too low, you want to start with something not low flow. You want something high flow. Another reason, another factor to determine the device. What else? You said something? You can, it's part of it. Like I'm talking about which one you will decide. Which one you will choose. Which device you will choose. She said, according to oxygen saturation, I will choose a device. What else? Sometimes you have obstruction. Let's say nasal obstruction. So maybe you cannot use nasal cannula. Okay? Sometimes patient don't like something inside their nose, or patient does not like something blocking their face. Okay? So you are looking for patient comfort. You are looking for how much oxygen needed. You are looking for obstruction causes, etc. So requirement, and you want also efficient use, you want patient comfort, you want how much of I2 needed. So there are oxygen devices Okay, variable performance and fixed performance. So variable performance, when you deliver the oxygen, you are not 100% sure this will be used by patient. Okay, or like the oxygen is delivered is this much, but you are approximately. While high performance, fixed performance, it will give you always fixed flow. Fixed flow. So variable performance like nasal cannula and mask and bag mask. While fixed performance like high airflow oxygen enrichment devices, Venturi mask, okay, or ventilators. Okay, ventilators is fixed performance. What you give, the patient gets. Okay. Variable performance depend on oxygen flow, how much you are that change the flow, and the patient himself, is he taking, let's say, rapid breathing or slow breathing pattern like our colleague said. Device also, the device, is it attached properly to patient? Is it off the patient? Is it the proper size of the patient? So nasal cannula, when you attach the nasal cannula, okay, who can tell me how much oxygen I can give with nasal cannula? 4 liter maximum. Okay. So why you don't give more than 4 liter? What if you give 8 liter with nasal cannula? What will happen if you give more than 4 liter, 8 liters? Huh? Just I want to listen. Huh? What? Capacity is for capacity of what? Nasal tube. I mean, if you try to increase the flow to 15 with nasal cannula, what will happen to the nasal cannula? It will not blow up. It will still give the flow. The nasal cannula, if you hold it like this and you increase to 15, then still it will deliver. But I need oxygen now. If I have oxygen toxicity, it will. If I already have oxygen, I give more oxygen, more than needed. But he needs oxygen, I will increase the flow to 8 because he need more oxygen. So I'm not worried about oxygen toxicity. It's the capacity of the nasal cavity. This nasal cavity have a capacity. Okay? This capacity limit up to 5 to 6 liter. Above that, okay, you will have more complication and less benefit. Like this cavity inside, there is mucous membranes. It can be easily dry, lose moisture, and it will be inflamed. Then you will have discomfort. You may even have bleeding. So you don't want to deliver more than 6 liters per nasal cannula. Okay? For face mask, now you want, why you need face mask? Why would you use face mask? Now, why you move from nasal cannula to face mask, for example? Give more oxygen. Yeah, if you want to give more oxygen, because nose have capacity limit. Okay, another thing, another cause I mentioned also, patient comfort. Patient comfort. He is not comfortable with the nasal cannula, you may try to face mask. But you have advantage with the nasal cannula. What are the advantages with the nasal cannula? Huh? The size? When you have nasal cannula, the first is the face mask. It will be here, covering the nose. Think about the patient, he wants to do other activity other than breathing oxygen. What other activity? Eating, talking. Okay, easy with the nasal cannula. The more difficult with the face mask. Okay, but if you need more oxygen, you need to put higher flow device. So higher flow limit up to 10 liters can be given with the simple face mask. And what makes a simple face mask is just a mask cover the nose and the face and try to use a proper size. And it has holes from the side. These holes allow the exhaled air will go out. Okay? Then fresh air will come in with the oxygen. So there is not only oxygen, there is also room air. there is also room air coming from this hole. When you inhale, the air will come from the room air and the oxygen. So the air coming from here and air coming from the tube. Okay, this is called mixing devices. Mixing devices. Okay, so it can reach flow rate. If you are giving up to 6 liters, can reach up to 40%. 8 liters can reach up to 60%. I will give you easy calculation. Each 1 liter add 4% to the room air FiO2. What's the room air FiO2? Sister, what's the room air FiO2? If you are not with me, I will ask you a question. What's the room with the air FiO2? What's the room air FiO2? Huh? FiO2 for room air. Huh? 21%. 21%. Okay, guys? 21%. For 21%, you have room air. All of us breathing 21%. Each 1 liter extra, 4%. So now 1 liter, how many percent?
4%.
No. Plus room air. Add room air. 25%. Now 2 liter. Huh? No. Not double. Add only 4%. 29%. Okay. Now you have 3 liter. 33%. Now 4 liter. 37%. So you add 4 liter each time, 4% each 1 liter. Okay. This is for mixing devices. I add room air, FiO2. If you don't use the mixing devices, that device that have pure oxygen only, don't mix with the room air, like non-breathing mask, you will not add this. You will not add this. Okay, you will not add the FiO2 of the room air. Non-breathing mask must have bag like this. Must have bag like this, okay? And this valve. See, this valve is very important. I told you, in the simple phase mask, I have open hole. With the non-breathing mask, I have covered the hole with a valve. This valve allows the air to go out, not to go in. So the patient will exhale. This air will go where? Outside. But when he inhale, the valve will close, then he take oxygen only from the back. Okay? So it must start from 10 liter. Because I'm thinking that his oxygen consumption should not be less than 10 liter. Or air, how much air he's taking per minute, should be 10 liters at least. Make it 15. How can I know 10, 11, 15? See this bag? It should be always inflated. If he inhale and the bag collapse, means he need more. So you make higher flow, increase the flow. Okay? Clear? So it gives you higher oxygen concentration because he is taking now pure oxygen. Does not mix with the room air. So this oxygen from where? From the wall or oxygen cylinder. Okay? Venturi mask. Venturi mask is called fixed performance. And there is colors. You saw this one before? Yeah? Anybody didn't see this? This each one have different flow. Each one have different flow. So you have this will give you 24% if run at 2 liters. White one it will give you 28% at 4 liter, and green one will give you the highest flow, 60% FiO2 at 15 liter. Okay, so you have to see how much flow if you want to achieve this FiO2, 60%. Okay. So there is something called the Venturi principle. The Venturi mask is work on the Venturi principle. What is Venturi principle? First of all, I will run the oxygen from the Venturi mask, and I have this way, the oxygen coming from this direction. Okay? There is another opening from the side. This will attract room air in certain speed. Certain speed. So I have total flow of the oxygen, let's say 10 liter. and I will have another oxygen, another air volume coming from the room. So if you will have another 5 liters and you add 10 liters of oxygen, the total will be 10 and 5, 15. This 15 will go to the patient to inhale. When he inhale, he will take all this volume. He will not take any other volume from outside. So I know calculated how much is delivered to the patient. I should give enough amount to equal or exceed the patient need. If he is taking oxygen, let's say breathing per minute, how many times he is breathing, and each breathing he is taking 1 liter. Is he breathing 15 times and each breath 1 liter? How many liter he needs? Each time 1 liter, and he is breathing 15 times. How many liters per minute he needs? 15. Why you are shy? 15. So you need to make total 15. When you make a total 15, he will only breathe from the mask, and then you will have fixed performance. Okay? So what's oxygen toxicity? If you have more oxygen, first it will damage the wherever you are putting the oxygen. Maybe it will damage the nasal cavity, then it will damage the lungs, then it will damage even the cells in the body, because there is the oxygen itself. If increase, it will release something called free oxygen radicals, and it will even cause damage to the other tissues. So it will affect the lungs. It will cause atelectasis in the lungs, collapse in the alveoli. It will cause even convulsions. So don't allow the patient to stay on 100% oxygen saturation more than 12 hours. Don't allow the oxygen FiO2. Don't allow the patient to stay on oxygen FiO2 100% more than 12 hours. FiO2 80% should not exceed 24 hours, and 60% should not exceed 36 hours. Okay? Any questions? Clear? Is it clear? So PO2 to measure what? PO2 to measure what? Oxygen in the plasma. Okay? PVO2. Venous oxygen in the plasma. Okay. Clear? Thank you very much.